let's go over the basics of hernia. So hernia is one of the most common surgical problems, and also one of the most common patients encountered in medical offices. So hernia is by definition a rupture in English, and it has been recorded throughout history. There are descriptions of hernia reduction dates back to Hammurabi of Babylon and the Egyptian papyrus. Hernia is and can be either an enlargement of a natural orifice, just like patent processes vaginalis in the groin, or hiatal hernia, or an umbilical defect, or a new or created defect due to tissue compromise or surgical or non-surgical trauma. Hernia, by definition, is a collagen disease. Means there is a fundamental defect in the processing of collagen. To that, smoking adds an incredible insult by enhancing neutrophil elastase activity that causes collagen quality defects that can contribute directly to hernia recurrence or development of initial hernia. Contrary to the common belief, physical activity per se is not a cause of inguinal hernia specifically. It has been shown that hernia is no more common in Olympic weightlifters than in general population. However, when it comes to body weight, obesity is a risk factor for ventral abdominal hernia, but it appears to reduce the risk of groin hernias for an unknown reason or mechanism. Hernia is like basically an endemic problem. It's 5 million Americans have hernias, and each year 700,000 will have it surgically repaired. First description of hernia officially dates back to 1804 by Sir Astley Cooper of England, who defined hernia as failure of the transversalis fascia and the peritoneum, which is the fundamental reason for hernia over the entire abdomen. So the integral layer of the abdominal wall is the transversalis fascia, fascia transversalis, FT, and failure of that layer is the direct cause of hernia, not the anterior fascia, not the muscle. Scope of our service as far as hernia, specializes in all kinds of hernia repairs, from traditional to open technique to more complex laparoscopic and robotic surgery. As a personal number, I perform about like 400 hernias a year, which has been my passion. From the simplest to the most complex redo repairs, even those with who have lost their abdominal domain. Few words about approaching hernia and when to refer a hernia patient and when to expect that hernia should be repaired. Basically, any hernia with symptoms, regardless of hernia size, should be considered for repair and referral for a surgical evaluation. Any hernia that is visible as a visible bulge, the recommendation is this hernia, when it is seen on the external abdominal wall, then it's large enough to cause future bouts of incarceration and strangulation, and the recommendation is for surgical consultation when it's visible. Small hernia that can be felt only on physical exam with minimal symptoms, meaning pain on and off, occasionally with activity and not impacting daily activity of the patient, can be safely watched. In the past, all hernias of all sizes of the abdominal wall were repaired regardless of symptoms, on the merit that these hernias will strangulate or incarcerate. the paradigm has in management has shifted, and now small hernias that are not visible with minimal or no symptoms can be watched safely. 5 to 7% of these patients will develop symptoms over 2 years of follow-up and will have their hernia repaired in that time. So it is safe to watch small and asymptomatic or minimally symptomatic hernias. If the hernia is visible, large, or symptomatic, then repair is indicated and surgical consultation is recommended. What kind of repair, if the patient asks you, would be recommended? Minimally invasive surgery can be applied to all kinds of hernias, but they have their certain indication that have shown remarkable benefit over open technique. And these are the indications. Bilateral inguinal hernias. When you have bilateral inguinal hernias, the approach will be the same, 3 small incisions above the level of the umbilicus that can take care of both hernias at the same time. So that's a major benefit over open technique. Recurrent inguinal hernias after open repair. To avoid going through a scar tissue or a previous mesh placement, laparoscopic or robotic surgery is the standard of care for recurrent hernia after open repair. Groin hernias in all females, the standard of care should be repaired minimally invasive laparoscopically or robotically. Why? Because females will have more incidence of associated femoral hernias that can be missed doing an open technique. And repairing them laparoscopically or robotically will patch both inguinal and femoral canals at the same time. The last indication for laparoscopic intervention would be the morbidly obese. Statistically, a morbidly obese patient will fare better with a minimally invasive approach because we avoid local wound complication, including hematoma, seroma, and wound infection. For ventral hernias, all ventral hernias with fascial defects more than 2.5 centimeter, not the size of the sac, but the size of the fascial defect. If it's more than an inch, then minimal invasive approach has the advantage because it allows us to avoid raising subcutaneous large flaps. Complex hernias that are typically more with fascial defects more than 7 centimeter should preferably be fixed by an open complex technique with component separation. The last note on this section is indication for robotic surgery. It's the same indication for laparoscopic surgery. So any patient who qualifies for minimally invasive repair should automatically qualify for robotic repair. Outcome of minimally invasive surgery has impacted the choice of surgery over the past decade or so, with specifically faster recovery and less postoperative pain that we're going to cover shortly. We recently acquired the Da Vinci XI robotic system at Nazareth, and we have been shifted to the robotic approaches for 99% of our hernias. The robot consists of 4 arms, 1, 2, 3, 4, numbered, that allow us to insert the instruments through these arms into the abdominal wall, into the abdominal cavity. So basically that's the picture that describes how the robot works. Port placement will be more or less just like a laparoscopic approach. Ports are a little bit bigger, they're like 8 millimeter in size, standards. And then these arms of the robot will be attached to each of these ports. And the instruments will be slid through that arm into that port. And then the surgeon will take control. So typically, that's the OR setup. The patient is on the table, bedside nurse, scrub nurse at the bedside with the robot arms docked and deployed. The surgeon typically sits in the corner of the room have full control on all the arms of the robot with his two hands, using also foot pedals as well. So these basically are the fine rested movements of the robotic console, and this is the robotic consoles, and this is a close-up view of the console. So it's worn just like a glove in a video game, and as you can see, all the movements are at the wrist level, which will allow really us a finer dissection, which is a major advance as compared to the laparoscopic surgery, rather than moving the elbows and the shoulder. Very advanced equipments and technology allow us to do very fine dissection in a very confined spaces that were never possible with the laparoscopy, now being performed routinely with the robot, with the help of the robot and the robotic arms. One of the biggest differences between laparoscopic surgery and robotic surgery has been the visualization. Laparoscopic surgery uses 2D images, whereas the robot will provide excellent 3D images. We just talked about the precision and wristed movements that is allowed in the robot that is missing in the laparoscopy. With the use of finer dissection and suture technique rather than laparoscopic tacks and tacking guns, mesh fixation has never been easier, and that contributed to definitely less associated pain. From a personal experience, an inguinal hernia patient will use about 12 pills with the laparoscopic technique and the open technique. When we do them robotically, they will use on average about 4 to 6 pills. Duration of pain is remarkably less based on personal experience. Patients have less postoperative pain with the robotic approach for obvious reasons. We're avoiding the tacking gun and using sutures and closing the peritoneal defect on top of the mesh, covering it completely. Utilization of the robotic system has really made the numbers of hernia being done in a minimally invasive approach really remarkably increased over the past 3 or 4 years with advanced technologies incorporating the robotic technology from Intuitive. Why our program? So the comprehensive hernia program at our hospital is like the word says, truly comprehensive. We take care of all kinds of hernias, from the simplest to the most complex. Personally, as I mentioned, I do about 400 hernias a year. Hernias and hernia repair is my passion. We have a multi-specialty approach from anesthesia, pain management, PT, including also plastic surgery if needed. We're implementing and have implemented the enhanced recovery after surgery pathway, which is a patient-centered pathway aiming at reducing post-surgical stress. This pathway starts in 3 different phases: preoperative, intraoperative, and postoperative. The aim of which is to disrupt the post-surgical stress response. That will eventually contribute to less inflammatory response, mobilization of less inflammatory mediators, less postoperative swelling and inflammation. That translates into less postoperative pain, earlier return of bowel function, earlier return to activity. So the ERAS enhanced pathway starts preoperatively with patient education, including even education on incentive spirometer use at home, breathing exercises and light exercises preoperatively, as well as, most importantly, preoperative carbohydrate loading. So traditionally, we have the patient fast for 8 hours before surgery. With ERAS pathway, we're asking them to fast for only 2 hours, meaning they will be specifically asked to have a carbohydrate-rich drink, which is 12 ounces of either Gatorade, grape, or apple juice that is non-pulp, 2 hours before the time of scheduled surgery. That will help replete the carbohydrate stores in the body and interrupt the post-surgical stress response. During surgery, we have multimodality nausea vomiting medication based on patient markers and indications, plus very limited use of IV fluids intraoperatively as opposed to liberal use of IV fluids. So in open cases, we use 5 cc's per kilos per hour of IV fluids. And in laparoscopic or robotic cases, we use 3 cc's per kilos per hour of IV fluids. That will limit the IV fluid infused during the entire procedure to less than 700 cc's at most in a 1-hour procedure. That greatly helps and limit postoperative swelling. That translates into less postoperative pain and earlier return of bowel function. That is being fully incorporated in our practice at Nazareth Hospital. We use, again, the latest available innovation with the Da Vinci Xi platform. And on top of that, as a team, we are committed to being available and see patient within 24 hours. In the morning, we can see them same day. The consultation comes late in the afternoon. We can see them the very next morning in office. That will allow us to provide timely care with improved patient convenience and satisfaction. As far as specific questions about hernias, I'll be happy to take them in the next 15 to 20 minutes to answer any questions or clarify any of the information that I went over previously. And thank you all for attending this activity again. Thank you.
All right, so I'll open it up for any questions for Dr. Nasir. You can either type them in the chat or you can just take yourself off mute and ask the question. Great, so there's one in the chat. Dr. Nasir, who qualifies for a robotic repair?
All right, any patient who qualifies for laparoscopic repair automatically qualifies for robotic repair. And there's certain classic indication that literature and evidence-based information available has more advantage over the open arm. The four-mesh groups, people with bilateral inguinal hernia should be repaired robotically. People with recurrence after open repair, hernia recurrence after open repair should be repaired laparoscopically and robotically. People who are morbidly obese should be repaired robotically and laparoscopically because there is an advantage in terms of avoidance of local wound complication. And females with groin hernias should be preferably repaired with laparoscopic robotic approach so we can patch the high incidence of associated femoral hernia. On top of that, all ventral hernias with a fascial defect of more than 2.5 centimeter, 1 inch fascial defect should be repaired laparoscopically or robotically for better outcomes, less pain, and less wound complications.
Thanks. So the next question is, how long is the expected recovery time?
Thank you. So the procedure, most of them will be a same-day procedure. If we are fixing a larger hernia, then that might be a 1 or 2 day hospitalization for pain control. Expected recovery should be a week. Limited activity should be not more than 2 weeks. So that makes it a total of 2 weeks with return to work after 2 weeks with full activities allowed after robotic repair, as opposed to the open repair, which will take a bit longer for the tissue to incorporate because you're putting the mesh in a different plane. Usually takes 3 to 4 weeks.
So one of my own personal questions, Dr. Nasser, in talking to some patients, there sometimes is a little bit of anxiety about the robot because the physician isn't necessarily at the bedside. So how do you handle that discussion with your patients, and what
Yeah,
would you share to the providers so that they can also help
that's
alleviate that fear?
that's a great question. So as you saw from the images, surgeon is sitting away from the table. Uh, in laparoscopy, as opposed to robotic system, I have 2 hands, so I can only hold 2 instruments, and the assistant will hold the remaining 1 or 2 instruments, including the camera, because I can't do all 4 hands at the bedside. The advantage of the robot is there are 4 arms of the robot that can hold the 4 ports and instruments all at once and give the surgeon full control over the 4 arms. So put it in a simple way, the surgeon has full control on all arms inside the abdominal cavity and is not reliant on the assistant. So the robot actually will allow the surgeon to avoid mistakes or possible injuries that can be caused by less experienced assistants. So that's the major advantage that the robot has offered. It's a full control of all instruments by the surgeon. So nothing moves unless the surgeon moves it. So this is a great advantage and a superiority of the robotic system as compared to laparoscopic system. On top of that, as I mentioned, the robotic console will allow us to do wristed movements based on the wrists and not the elbows or the shoulders. And that translates into a very finer movements and dissection in a very confined spaces very safely. And that's also another major advantage. Thank you.
Okay. Does anyone on the line have any other questions for Dr. Nasser? Next question in the chat is hospitalization required?
Well, the hospitalization, again, 90% of the robotically repaired hernias will be a same-day surgery. If we are all groin hernias will be same-day surgery, regardless whether they are initial or recurrent. Even if they are bilateral, they are same-day surgery, so it's an outpatient procedure. As far as ventral hernias, that depends on the size of the defect and how much needs to be done. Larger defects, 5-6 centimeters with more dissection, may be associated with a little bit more pain compared to smaller hernia that may require an overnight stay for pain control. So basically, at worst, it's a 24-hour overnight stay. More than 90% would be a same-day procedure.
The last question I see in the chat is, when should we refer hernia patients to the surgeon?
Thank you. So again, per the new paradigm shift in hernia management, all hernias that I can see visible bulge, I recommend hernia repair. Or hernias that you can't see bulge, but the patient comes with groin pain or abdominal pain, or the small hernia should be referred for a surgical consultation and consideration for repair. All incisional hernias that occur in an abdominal incision, should be referred for repair because incisional hernias are statistically at higher risk of incarceration and strangulation. All incisional hernias should be repaired surgically, no exception, unless the patient is medically unfit. Then that's a different story. All incisional hernias should be referred. All hernias that are visible at the abdominal wall level or groin level should be referred because statistically they are associated with more incidence of strangulation and obstruction. And hernias, regardless of size, that are symptomatic. Abdominal pain around the hernia, groin pain with hernia diagnosed on careful physical exam also qualify for a surgical consultation and repair.
So, Dr. Nasir, as the program director for robotics at Nazareth, what are the procedures that we're offering currently on the robot?
As far as general surgery, I'll start with the general surgery. We're offering cholecystectomy, all kind of hernias repair, from the groin to umbilical to incisional and ventral, lumbar, and hiatal hernia. All are being repaired robotically. Cholecystectomy, as far as bariatric, robotic sleeves are being performed by my partner, Dr. Chiandera. Colorectal, offer also robotic colectomies, right, left colectomies and LIRs robotically with superior advantages over laparoscopic or open colectomies in terms of speed of recovery and outcomes, backed up by abundance of literature and evidence. Urology is in the process of credentialing for robotic prostatectomy and nephrectomy and ureteric procedures, Dr. Laganowski. GYN, two surgeons are being credentialed. One of them finished her lab training and being credentialed for her proctored cases. So GYN surgery will be available as well. So pretty much all procedures that can be done robotically are being offered, will be offered at Nazareth Hospital, including also thoracic surgery, Dr. Sharif. So in short, it is a comprehensive program. At the time being, general surgery, colorectal, and bariatric are active. Urology and GYN and thoracic are in the process of credentialing.
Great, thanks. All right, so that looks like all the questions in the chat. If anybody has anything else, please jump in. Otherwise, we're going to go over one more time the attendance. I think we have one person who has the identification of DZZQ1907. Can you identify yourself so we can get you credit for this session? You might be on mute if you're talking.
Hi, they need to get the credit themselves. We won't be issuing credits. They need to go to the link, claim credits, create a profile, then enter the event ID number. Please note the event ID number will be different for every CME activity we provide.
Okay, and the other phone number that I don't have a name associated with is 2153, and then the last two digits are 97. Who is that? All right, so I think that's everybody that I identified that I didn't have a name with. So, like I said, the DZZQ1907 or the 215 ending in 97 phone number. Not sure who you are. Can you identify yourselves?
Nicole, I guess we can ask if there are any folks on the line that have somebody sitting with them that should earn a credit, but not necessarily logged on, but is with somebody who logged on. Is there anybody out there today?
All right. Then, as Kathy mentioned, there's also in the invite for this session, there was how to access the CE pages. So please refer to that. You have 30 days to complete the evaluation and claim your continuing education credits. And as Jean noted, you would go on and you would build your profile, and then you'd have access moving forward to other offerings. We will be offering these monthly, rotating different surgical specialties to include all of surgery, GI, oncology, and cardiovascular. So I thank you for your time today and joining us on our first session.
Thank
Nicole,
you.
Yeah.
did you want to tell them when our next session will be?
Oh, yeah. Do you have the date, Kathy?
Yes. So the next session will be with Dr. Jaffe, and he is scheduled on June 11th. So that'll be our next one. But we will be advertising this, so please stay tuned for the flyer.
All right. Thank you, everyone, for attending. Have a great rest of your day.
Thank you all. Thanks.
Thank
Thank you.
Thank you, Nicole.
Yep.